Okay, good morning. So, thank you for joining me on week 14 on the Monday morning session. So, this week, as typical with the exam and practical weeks, we are going to have actually 4 sessions during the week. And this is the first one of those on the Monday morning. We will have another one today on Monday in the evening at 8 p.m. And then we have 2 further sessions on the Wednesday, one in the morning at 10 a.m. and one in the evening at 8 p.m. So why don't we just jump right into it and get started? So I do know that there's a couple of messages that I'm still yet to answer on Canvas. So I just want to ensure you that I will be getting back to those in next few hours. Few of them were about extensions or due dates, and I will naturally respect those and make sure that you have chance to work through those assignments before you take the exam this week. And for this week's goals, I really want to focus us on the study guide for the exam 3, but we'll talk about a few other things as well as typical. And at this point, I think it's a great time to kind of take a quick breather and quick recount of where we are with the course. So we remember week 9 was supposed to be our spring break. I'm not able to write there, so let's just see if I'm able to get that somehow else by. Well, week 9 was supposed to be our spring break, and as you remember, the week 10 was extended spring break. And we got back for the week 11, and since the spring break, we have covered the chapters on respiratory, urinary system, and water, electrolyte, and pH balance. So this week, we are going to do a test that covers those 3 chapters. And I want to prepare you for that test as typical with the exam 3 study guide. But I think it's a good time to remind ourselves that we're about 3/4 done with the course. I know that in terms of the actual dates that you've been on this course, we're even a little bit further. But in terms of the week load, once you have made it through this week, we are on the final stretch of the course. So hang in there. And as typical on the exam and practical week, there are no new assignments due this week. Instead, what I'm asking you to focus on is completing the exam and completing the lab practical. And both of these are due at the end of the week, which is the Sunday, 25th of April. And as you can see, both of these carry quite a bit of points. So it's definitely worth making sure that you get a chance to tackle those. If you do have an accommodation version of either one of these, you will be using the same password that you have used before. So that should open your individual version of the exam and lab practical. And as I've said before, the study guides are really worthwhile when you're preparing for the exam. So study guides cover all of the material from the chapters in question, and every single question in the exam is drawn from the study guide either directly or indirectly. So let's jump off from this presentation. And what we are going to do, we are going to focus on the study guide for this week. So let me just stop sharing, and we're gonna move on to the study guide, which I should have open for you here. So you should be able to see now Adobe Reader, PDF Reader. So this is what we will be using to guide us as we work through the study guide. And as I've said before, the study guide should be open for you in a blank format on this week's learning module. And this is the only time that we actually cover the full-on answers to the content of the study guide during these lectures or weekly review videos. So we're going to start with the respiratory system. That's going to be the first chapter, chapter 22, if I remember correctly. And as always, I just kind of want to make a couple of systems links highlighting how a respiratory system ties into everything that we have seen so far. So earlier on, we have talked about the cardiovascular system, and we noted that it was all about transporting materials. So this included, for example, gases, our oxygen and carbon dioxide. And it also included our nutrients. So what we use for example, as building blocks of the material of the body, and of course the ATP sources, sugars for making ATP, which is the cellular energy currency, getting rid of the waste products. We saw at the beginning of this course that cardiovascular system played a great role in also transporting the hormones. Then we saw that the lymphatic and immune system worked as a kind of a complementary system to the cardiovascular system, catching whatever leaks out. We had few other functions that we also saw. One of those big ones was the protection against pathogens. And if we relate this to the respiratory system, of course, the respiratory system is an open path from outsideward through our nasal and oral cavity down all the way to our lungs and alveoli, the final smallest structures at the end of the respiratory tree. And because of this structure, because of this layout, we have a risk of pathogens being able to enter into our respiratory system. So lymphatic and immune system play an important complementary role on dealing with those pathogens. We also talked about the urinary system, and we saw the urinary system's main function was blood pressure regulation. In addition, we had a bunch of other functions such as cleaning the blood, eliminating materials from the blood, and regulating the fluid balance throughout the body. What urinary system really does as it relates to the respiratory system, any hydrogen that we cannot breathe out through the respiratory system, that's as a byproduct of the cellular respiration, well, we get rid of that by the kidneys. So it does play an important role there as well. So this has been just kind of setting the stage for us to have an appreciation why the respiratory system is important and how it relates to the other structures that we have seen so far. And we talked about the respiratory system being one of the three most important things that we would do in a first aid setting or emergency response setting. And we noticed that we dedicated out of those three 2 functions for the importance of respiratory system. So we want to secure that the airway is clear. And then if there is still no breathing, we want to do assisted breathing through the rescue breaths. And we also saw if the cardiovascular system wasn't working, then comes the chest compressions, which were the way of artificially trying to maintain some of the movement of the blood in the body. Why respiratory system is important? This all goes back to cellular respiration, as we recall. So in cellular respiration, we take sugars, and we change those sugars into ATP, which was the energy currency of the cells. But to do that, we do need to get oxygen from the outside air and deliver that into the body. And as a waste product of this process, we are left with carbon dioxide. Another waste product that we will have to deal with is, of course, the water. And some of those of the carbon dioxide and water, we can get rid of through the respiratory system. For some of those hydrogens ions, as I said here earlier on, we will have to recruit also urinary system. But what we see here is that clearly this oxygen and carbon dioxide transportation becomes very important for us. And let's have a look of really what could we take away from this diagram or this formula. Well, we notice that it's transporting oxygen into the body and getting rid of the carbon dioxide, which were the two single most important functions as we relate those to the respiratory system. So in addition to that, respiratory system had a couple of other important roles. The sense of smell, and the proper term for the sense of smell is olfaction. And also respiratory system plays an important role in our speech and speech production. Okay, let's have a look at the parts of the respiratory system. So there are main organs, main parts of the respiratory system. We're going to start with the nose, and the external nose are nares. So the entryways for the air. We'll talk about the hair within the nose, what function it plays. Then we'll move on to look at the nasal cavity. Nasal cavity as well has three important functions, and we'll list those in a more detail. But at this point, we see that nasal cavity plays role in humidifying, in heating or warming, and then also filtering or removing small particles from the air that passes through. So to do all this, we have to have special adaptations on the nasal cavity, and we'll have a look of that. We'll also take a little bit of time to discuss about paranasal sinuses. So sinus was always an empty space within a structure. So we have empty space within the skull of the head. And we'll have a look of that. We'll talk about pharynx and larynx. Larynx, especially as it relates to the role that the vocal cords have for that in producing the voice. Then we'll have a look of the trachea, which is sometimes known as the windpipe. So we'll notice the trachea has this cartilage ring structure, and we'll discuss about the shape of those rings and why this structure is important as we look at the trachea. We'll also talk a little bit about the further branches. That includes the primary and secondary bronchi. And we'll talk about bronchioles, which are smaller versions of the bronchi. We'll talk about lungs with all of the lobes of the lungs and specific shapes that we can see for the lungs. And we'll finish off by having a look of the alveoli. So there's a good amount of things to cover. We won't dive into it too deep of a level on any of those, but we'll certainly be able to remain busy. And let's start by having a look of the nose, as I said. And air typically gets taken in through your nose, It is only when we need to recruit additional route of taking in additional air when we recruit the mouth for that purpose. So normally breathing through the nose, which allowed us to do all of these three important main functions of the nasal cavity: humidify the air, heat up and warm the air, and filter the air. Typically that all works out great by using the nose for breathing. We do recruit the mouth whenever there's a need for additional air to be brought in or gotten rid of. And that's why, for example, yawning, often we tend to, in a layman's language and in a folk psychology, think that people yawn when they get tired or bored. Really, yawning in a physiological sense is a response to an added need for oxygen, so the breathing through the nose is not enough. So what's the better way than to bring in your mouth and make it as large and big as possible, as such when you're having a big yawn. So that's why we tend to see that yawning spreads within the room. We'll have also look of a little bit of the nostril. So let's talk about the nostril, the single term nares, plural nares. And what we end up finding with the nostrils, which is really noteworthy at this point, is that there's this hair growing right at the entry to the nasal cavity at the nostril, and the function of that hair is to filter the air that enters in, kind of be the first line of screening, removing any large particles, anything that shouldn't be going into the nasal cavity. So it is really this filtering function that we want to pay attention. Let's have a look at the nasal cavity a little bit. So nasal cavity was lined by mucous membrane. So whereas we have skin covering all of the outer layers of our body, the inner parts, if you wish, that are still continuous with the external world, such as the respiratory tract, digestive tract, and of course from the other end, the urinary tract as well, reproductive tract. All of those are lined by mucous membranes. Mucous membrane is thinner layer than the skin, very sticky, very humid surface, and this is because of the mucus, which is produced by goblet cells. So goblet cells produce this sticky substance that's wet and lines all these layers of all these layers where we find mucous membrane. And the purpose of this stickiness is, as we saw, humidifying, heating, and trapping any particles that shouldn't be there. So screening the air that enters in as well. There are, if we look straight from an individual, here we have the eyes, and here we would have the mouth. Within the nasal cavity, when we remove the nose, we have the nasal septum that divides it into two. And then we have from the nasal cavity 3 protrusions coming out. And these are known as our conchae, these protrusions. And we have most superior one, middle one, and inferior one. And the function of these is, first of all, to increase the surface area. So we have more surface area to do all these functions that we saw earlier on. But also what they do, they generate this turbulence. If you think of it as a sideways horizontal tornado, so the circulation of the air within the nasal cavity, so the maximum amount of the air makes contact with the mucous membrane. I already mentioned the nasal septum being the middle line that separates the left and right side of the nasal cavity, and the floor of the nasal cavity is made by the palate. So again, if we have a quick look, there's our nose, there's our mouth, and an eye. So the oral cavity is separated from the nasal cavity by this palate that we see here. And palate can be divided into two parts. The more anterior, oh, I didn't mean to do that. The more anterior part being known as hard palate. And the reason why it is known as hard palate is that we actually have a bony layer there within the palate on the anterior portion, at the front portion of it. And then when we move to the posterior portion, that is often described as soft palate. And that's because we don't have this bony structure there. And of course, at the very end, we have the hanging protrusion, the uvula that we've seen before. So that's what we have for the floor of the nasal. Let's have a look at what else we can spot. I mentioned the paranasal sinuses. So let's do a little bit of a diagram or a sketch together if you wish. And I'm going to sketch very quickly a diagram of the skull. So here we have the eye socket. Then we have our nose and we have our teeth, upper jaw, lower jaw on the mandible. And rest of the skull. So that's a side view. Let's do a front view as well. For the front view, eye sockets, the nasal septum, rest of the nasal cavity. Remember, this is the skull, so only the bony part, not the rest. And we'll do the lower jaw as well, the mandible, which comes up here. And rest of the skull. And of course, that's not to the scale, but that gives us a good starting point of what to spot, what we might want to spot from the paranasal sinuses. So as you remember, sinus was a cavity or organ, or cavity, empty space within an organ or tissue. And since we're talking of the region of the skull and face, it's gonna be paranasal sinuses that we're going to have a look at. Well, let's start looking at the different kinds of sinuses. There's 4 that I want to highlight that we have within this structure. And the first one, the frontal sinus, is located within the frontal bone. So that's why, again, if you learned these bones back in the day, that's gonna be really useful, really easy. So the frontal sinuses form kind of this, where you would think of a little bit of the eyebrow being or so, empty spaces above the eye sockets. That's where our frontal sinuses are located. The next ones that we want to have a look of are going to be our maxillary sinuses. So maxillary sinuses are located within the maxillary bone. So let's add those to underneath our eye sockets. They're probably the larger ones here on both sides. And if we look at the side view underneath the eye, again, they don't extend too far back. Posteriorly, they're located only within the bony structures. The next one, let's look at our sphenoid sinus. So sphenoid sinus is located within the sphenoid bone. And you might remember that the sphenoid bone was located quite far back. So let's add that. It's going to be hard to see it really from the front view. So instead, we're just adding it to the side view, our sphenoid sinus. And finally, our ethmoid sinuses. Sometimes they are referred also as an ethmoid labyrinth. I actually personally think that the ethmoid labyrinth makes a little bit more sense to me because it turns out that it's not just a single sinus. It's a collection of sinuses that are connected to each other, and they are located here within the nasal area, within the ethmoid bone. So that's our ethmoid labyrinth. And of course, you might ask then a natural question that why do we have sinuses? Why do we need to have sinuses? And the truth is that some of the answers to this question are obvious. Some of the answers are still being debated. That's what I love about my field, that there's always a little bit of discussion going on. So the first and kind of commonly accepted argument is that having these sinuses reduces the weight of the skull. If the skull was a solid bone, having these sinuses helps us to reduce a little bit of that weight, so carrying the head is not as heavy of a task as it would otherwise be. Another function that we've noticed with the sinuses is that our voice, the tone of our voice, depends greatly on our sinuses, so that's where voice resonance takes place as well. The next one is a little bit more controversial, still being discussed. So you can think of, just as we have a car, which I've drawn a really simplified version here. That's our car with the headlamp. When you get into a car accident, if you've ever gotten, and I hope that you don't, what you'll notice is that the front of the car collapses in a crash, and cars are designed to do that because that collapse of the front of the car actually reduces the impact of the forces that are being absorbed to the driver, so that the stop is not quite as sudden. We don't get quite as strong of an impact, especially on the brain within the skull and so on. So there has been speculation that maybe the sinuses serve a similar purpose. If there is a collision head first, the bony structures of sinuses help to kind of absorb a little bit of that shock that would take place otherwise. I'll let you choose whether you believe in that, but that's one of the functions that we have discussed. And the final role that we've noticed with the paranasal sinuses is that they do play a role in the immune system, and that brings us to talk about sinusitis. You remember whenever it was an itis, it was an inflammation of something. So in this case, it's gonna be inflammation of the sinuses. A couple of other things that we do end up noticing within the nasal cavity, there is the opening of the auditory meatus. So auditory meatus is this connection from the nasal cavity to the inner ear, mainly playing role in pressure stabilization. So when we, for example, move in altitude, whether it's taking off on a plane or driving up a hill, or sometimes even going through the tunnel where the air pressure would change, you can hear your ears popping. Easiest way to avoid that is by making sure that you swallow regularly, bring in air to your nasal cavity, and that allows to even out the pressure differences between your ear and the inner ear. Well, these functions of the nasal cavity, we already looked at those a little bit. The main three functions were filtering, warming, and moistening the air that comes into the body. If you have ever been out on a cold winter's day where we have cold, dry air outside, and you've taken a deep breath, you might have noticed that you end up coughing away because the air that now enters into your body is not heated up, it is not moistened enough, and you end up getting a coughing fit as your lungs are not adapted for that. So that's why we do try to do these three functions within the nasal cavity. Now we are ready to move on to have a look of the pharynx. And pharynx is as I say there, a muscular tube. And this muscle type that we are ending up seeing with the pharynx is going to be, of course, the skeletal muscle. So pharynx runs all the way from the back of the nose all the way to the start of the larynx. And I think a good way to tackle this would be, again, let's draw a quick diagram. A sideways view of the body. There we have our nose, mouth. We would have our eyes here, rest of the head. And here we have our nasal cavity separated from the oral cavity by the palate. And going down, here we see our Adam's apple, and we start to see our larynx and separation of esophagus and the trachea on the anterior side and esophagus at the back. So let's look at the three different parts of the pharynx. What do we need to know about that? And let's start with the nasopharynx. As the name tells, a nasopharynx is the portion of the pharynx that's located immediately behind the nasal cavity. So that's our nasopharynx. The next part is gonna be our oropharynx. And again, not surprisingly, that's the portion that's located behind the oral cavity, behind the mouth. So let's add that to our diagram. Oropharynx. And finally, the last portion that I want to address with you, the laryngopharynx. Let's add that as well to our diagram. That's the portion right before, right superior to the larynx. So those are our three portions of the pharynx that we want to be certain about. Let's next have a look of our larynx. So larynx is a larger structure running on the vertebrae from the level of cervical third to cervical sixth vertebra, attaching right to the hyoid bone, which is located more superior to that. And larynx is made of a bunch of cartilages, soft tissues, and other connective tissues. We're going to be focusing on the cartilages that make up the larynx. And we're going to go through them. Again, I'm going to draft just a little diagram. Drawing a diagram is always a little challenging, but I think we can do that together. So let's start by looking at the, we can add our hyoid bone here on our diagram. So hyoid bone is the bone located right up here, kind of has two little tweaks, if you wish, and that's the bone that often gets fractured if someone's strangled to death. Not always, it's not a foolproof criteria for that, but is the most superior most part to the our larynx. Let's start by talking about the thyroid cartilage, which is the largest of these cartilages that we see with the larynx. Thyroid cartilage covers the largely the anterior portion of the larynx, and within the thyroid we notice this little bump here, and this bump is what we know as the Adam's apple. So this prominent feature on males especially, but also there within the females, known anatomically in a proper term as laryngeal prominence. And if you think of how could you locate the thyroid cartilage, think of where you would see then the thyroid gland. Well, thyroid gland is located overlaying the thyroid cartilage. So we can just sketch it in here. We remember that it was 2 lobes and connecting isthmus. That's our thyroid lying there. Next piece of our larynx that we're going to be having a look of is going to be our cricoid cartilage. Cricoid cartilage is actually the most inferior part, so the lowermost part of the larynx, and it's the only part of the larynx that forms a fully fused ring. So that's located there, if you want to consider that. I probably should, though, let me just correct that. Draw it a little bit higher so we just get that correct. So let me just erase this and move it a little bit higher so our diagram is more correct. Ooh, and we get everything erased, I think we can. So that's our cricoid cartilage there, a fully enclosed ring. Underneath the cricoid cartilage, we would then have our trachea starting with its rings. So that's the beginning of that structure. What else can we see within our larynx? Well, we can see a structure known as epiglottis. Epiglottis is this flap-like structure located behind here inside the thyroid cartilage. You can see a little bit of the peak of it poking out from there, but usually it's pretty much inside the thyroid cartilage. Its function is to seal off the trachea, so the airway, whenever you swallow, so you consume food, liquids, that has to go down to esophagus, which is located more posteriorly here to the trachea. Airway is kept open at all times with the exception of when we're swallowing. So epiglottis is normally open up in an open up position. So the only time when it is not, that is when we are swallowing. Let's add arytenoids. So arytenoids would be structures located inside the thyroid cartilage, and to draw those, I'm going to draw a side view of what we've just seen. So there's our thyroid cartilage. We'll just accept that it goes there. Our cricoid cartilage, and arytenoids are kind of these triangular structures located inside there. You can think of them looking a little bit like pyramids if you wish. And why it is important is that they are actually connected to a bunch of muscles, and these muscles help us to move these arytenoids, so to change their location, their angle a little bit. And by moving the location, changing the angle of the arytenoids, we're able to manipulate then the tension of vocal cords, which run from the arytenoids to the thyroid cartilage to the front there. So they play an important role in that movement, tightness of the vocal cords. Let's add one more structure on top of the arytenoids. These structures that I'm going to introduce to you are going to be our corniculate cartilages. So corniculate cartilages are located as tips on top of the arytenoids, one on each side, and you can think of them, like I said, as kind of a tiny top parts on top of the arytenoids. And finally, we get to the last cartilage type that's part of our larynx. And those are going to be our cuneiform cartilages. Cuneiform cartilages are going to be harder to see. They're located within the rest of within the mucous membrane lining of our larynx, so we never really see them. They're just located within the wall in there. In addition, as I said, there's a bunch of muscles, elastic tissue, soft tissue that contribute to our larynx, but we are focusing on the cartilages on this discussion. So that's our larynx. What is the function of the larynx? Well, we kind of touched upon on some of that already, but of course, we're going to do a better way than just that. We're going to cover everything. So larynx is the path for the airway. Let's change our pen color just so that we're consistent. So it controls the air, separates the air that should go into the lungs, and food that goes down to esophagus. So we are separating the trachea and then our esophagus. The important function that we saw for the larynx was the voice production, and this was all due to those vocal cords and controlling the tightness or relaxation of the vocal cords, as we discussed. An important or interesting thing to note about the vocal cords is that they are made of elastic fibrous tissue. So because they're elastic fibrous tissue, they are able to do this tightening and loosening. We also noticed that they're white in color, which tells us that there is no blood vessels running within the vocal cords. And if we have our vocal cords here, let's add our arytenoids to the end. And of course, our cricoid cartilages would be on top of those. And this all attaching then to the thyroid cartilage, which we saw kind of enclosing all this. This space between the vocal cords is going to be known as glottis. Sometimes also described as rhimaglottis, which is the proper full name for this space, this area. But this is where the air flows through. We actually have two sets of vocal cords. The more superior ones are often described as false vocal cords, and that's because they do not contribute to the voice production. Oh, I didn't mean to use that color. Let's change the color here. So these superior ones are known as vestibular folds, whereas inferior ones are known as vocal ligaments because they are the actual true vocal cords. They are the ones that play a role in the voice production. Of course, here I was meaning to keep the color of the glottis, the rhimaglottis here, matching with our notes. So apologies for that changing. So I think that we're pretty good with our discussion on the larynx. Let's move on to talk about the trachea a little bit. And trachea is about 4 inches long tube running from the bottom of the larynx all the way where we then divide further into the respiratory tree. And one thing that's characteristic for trachea is that I talked about how it had these cartilages structures that were then connected to each other. This is a side view if you wish to look. So we're seeing those rings and they are connected to other parts and so on. But let's have a look of what we can see here. Here we have the head, we have the nose, we're looking to the left side. And now what I'm gonna draw is gonna be these cartilage rings that are actually C-shaped. So they take the shape of a C if you wish. Of course, this isn't totally to the scale. This is a little over exaggerated. And these rings keep the trachea open, even if all the tissues in the body relax, because these cartilage rings are rounded, trachea remains, our airway remains open. And this, of course, was very important if we go back all the way to the very start, where we remembered that keeping the airway open was always important for us. So that was one of the important things that we wanted to secure at all times. Well, logical next question would be that why are these C-shaped, these rings that make up the trachea? Well, let's have a look of a little bit of that, considering what could be the explanation. And we remember that our trachea is going to be located more anteriorly, whereas our oesophagus, so the path to the stomach, is going to be located more posteriorly. And what we notice, our oesophagus is typically squashed closed when it's not being used, so it's kind of nice and shrank. Sometimes though, we end up swallowing large objects, and they can be so large that we need to make a little bit more extra space, and this is when the opening at the back of the C-shaped rings that make the cartilage of the of the trachea is useful. Oesophagus can kind of protrude a little bit inside there. And apologies, my cat decided to make a surprise visit. Please don't step onto the steps. Well, if we keep continuing looking at the trachea, eventually at the end, let's change the color of the pen. At the end, we end up noticing that the trachea divides into two primary bronchi. And these are the first bronchi, so we're knowing them as primary bronchi. This spot where the trachea divides into two. Oh, I lost my tools there. Bear with me, I'll pull them up. Sometimes we might need to know that spot. That might be an important identification that we reach this point. For example, when we put a camera down someone's trachea, look down. So this sharp end where we divide into two primary bronchi, that spot is known as carina. The other thing to notice with our primary bronchi is that the right one comes down at the steeper angle than the left one. And this explains why we often end up finding that if we have especially infants who have a tendency of putting everything and anything into their mouth that they find, we end up finding that most foreign objects end up on the right lung because of this steeper angle. So that's the explanation why we start looking at that. One clinical example that I mentioned here is gonna be the tracheotomy. In tracheotomy, we make an incision to the trachea if the airway above, more superior, is blocked, and we can make this incision so that the air is able to enter back to the respiratory system. So this would require some sort of a reason issue that has compromised the airflow from the areas that are more superior to what we have seen, or more superior and what we have seen within the respiratory tract. Next, let's talk about bronchi and primary and secondary bronchi. So the spot where a bronchi enters into the lungs. So here's our lung going nicely, and on the other side as well. This spot here where the bronchi enters into the lung, that's known as hilum. So that's an important term to know. Well, after our primary bronchi, which we just saw, we have smaller ones that are secondary bronchi. Then we can even have tertiary bronchi. We get to the smaller versions of bronchi. These are known as bronchioles. At the very end of the bronchioles, we have terminal bronchioles, which then lead to an alveoli. And we're going to have a look of an alveoli next. But before we move on and before we start talking about alveoli, I want to mention a couple of things about bronchi and discuss lungs just quickly. One thing that's noteworthy in terms of the trachea is that at the most superior parts of the trachea, we have more cartilage and less smooth muscle, but as we move down the respiratory tract, to these different subsequent branches, the amount of the cartilage decreases and the amount of smooth muscle increases. So there is this transition from one to another. Let's discuss lungs really quickly. And here I have actually given you on your study guide a rather nice diagram that hopefully will help you as you take your notes of the lungs. So let's discuss that together as well. So lungs fill the entire thoracic cavity with the exception of the mediastinum. And you might be wondering, what is the mediastinum? Well, mediastinum was the place where we had the heart located, you remember, slightly to the left of the midline, apex pointing downwards and anteriorly. And for this reason, we actually see a cardiac notch. So part of the left lung is actually taken by the heart. So left lung appears smaller than the right lung because of the heart taking the space away from there. So let's have a look at a few different parts that we need to know. So the ones that I want to highlight, we've talked about the apex in terms of the heart. Heart's apex was pointing anteriorly, inferiorly, and to the left. But the apex of the lungs is actually this top tip. Again, sharp edge pointing out there. So that's our apex. Base is going to be the inferior surface resting on the diaphragm when we talk about the lungs. And of course, the hilum, we already discussed about that, the site of entry and exit to the lungs by the primary bronchi. Okay, let's have a look at the lungs in more detail. We notice that we have our right and left lung, and they were very different. I already mentioned the cardiac notch as a consequence of the heart taking the space on the left-hand side a little more, and as a result, we are left with smaller left lung. So that's our heart taking some of that space. Well, because the left lung is smaller, we're going to see that it has less structures for us to learn, whereas the right lung being larger, there's more to learn. So let's start with, I'm going to do in reverse. I'm going to start with fissures. So those lines within the lungs. And we notice that on the right-hand side, we have a horizontal fissure and we have an oblique fissure. Whereas on the left side, we simply have the oblique fissure. We are left with different lobes. Again, more lobes on the right-hand side, so superior, middle, and inferior lobe, whereas on the left-hand side, superior and inferior lobe. We do have pleura lining the lungs. So another important structure that you might want to be aware of, made of the visceral, which was the innermost pleura, and parietal pleura, which is the outermost. And between them, we have this space where we find fluid, and the role of this fluid is to lubricate and cushion these layers, but most importantly, create the negative pressure, which keeps the lungs expanded so that they remain on their largest extended position as much as possible. So let's do that. That's our lungs and a little bit of trachea nicely there. So this fluid in between these pleural layers generates this negative pressure that then pulls the lungs open and big as much as possible. And that was thanks to this fluid between these pleural layers. A clinical example that I've given here is that if we have a puncture on this pleura, then we lose the negative pressure. That would be problematic. We end up with pneumothorax. So the lungs will collapse since there's no longer this negative pressure to maintain it open. I promised that we would talk a little bit about alveoli. So when we move to the very end of the respiratory tract, we reach the alveoli. These are small microscopic sacs. And to see them, if you look at them microscopically, you've seen various different cells so far. What you'll end up noticing is that alveoli are just really thin, made of thin wall, thin sacs at the end of the respiratory tree. And the fact that there's numerous of these is important. They form a super large surface area, but also their thin wall is ideal for materials to travel through. And what we notice is that there is a blood vessel capillaries running right next to the alveoli so that it is easy for the air that gets carried into the lungs and into the very last structure, to the alveoli, to be exchanged with the gases from there, to be exchanged with the gases within the pulmonary circulation. So that's where the exchange takes place, the gas exchange. That's the site for that. Let's have a look at a little bit of the physiological side of the respiratory system. So we're going to go through different phases of respiration, and there's going to be 4 that we're going to cover. And we're going to start with the pulmonary ventilation. This is when we bring the air from the, and I'm going to try to find a highlighter, from the outside world to the alveoli. And we remember that breathing in is active process as you're extending your chest cavity. So your diaphragm goes downwards. Diaphragm was, let me just remove this. Let's do that again together. So how does the air move? I'm gonna draw lungs here. That's our right lung and our left lung. And as you are breathing in, I mentioned that that is the active part. That's the part that takes effort. Normally, your diaphragm is located here. When you breathe in, it moves downwards, making the chest cavity bigger. And now your lungs grow bigger. And as a result, there's a low pressure inside the lungs and air moves in from the outside of the body where we have high pressure. This all takes conscious effort. We've discussed about the role of the diaphragm on that. In addition, we can have our external intercostal muscles playing a role. So intercostal meaning between the ribs, and external ones of those. But really, if you want to name one, it is the diaphragm that is the main respiratory muscle of the main respiratory muscle of this system. Whereas if you take in a deep breath and now you relax, air will flow out just naturally. That is because breathing out, expiration, is a passive process. That happens mainly thanks to the elastic recoil and surface tension. We can have a situation where we have also forced expiration, so we breathe out more than we normally would be. So in there, we are using our oblique abdominal muscles, our transverse abdominal muscles, and our internal intercostal muscles. All of those, in this case, to make our lungs as small as possible. So I'm gonna draw it here now on top of this. And because the lungs are small, there's now a high pressure there, and outside we have a low pressure. Air will move from the high pressure to low pressure, so out from the lungs. Let's have a look at the next stage. What we see at the next stage of the respiratory process, we actually see the external gas exchange. This gives you a clue that there's going to be another time when we see gas exchange happening. This external gas exchange takes place here. It's between the alveoli and the capillaries of the cardiovascular system. And the driving force was, again, this partial pressure difference where the materials move from high pressure to the lower pressure. We just had a look of that. And then gases do get transported. So that's our third stage. Within the systemic circulation, there's gas transport. So that covers all of this part of the loop until we get to the internal gas exchange. And let's add our internal gas exchange to the diagram. And that's where the materials get exchanged between the capillaries of the systemic circulation and the either interstitial fluid or tissues. So oxygen moves from the blood to the tissues and carbon dioxide from the tissues to the blood. There are multiple other air movements that really don't play a role in respiration. These would include coughing, sneezing, crying, laughing, hiccups, even yawning. I discussed those earlier on. They are important to note that not everything or movement of the air has a respiratory function. A couple of terms that I want to cover with you. Term surfactant. That's a lipid protein complex that reduces the surface tension and prevents the alveoli from collapsing, whereas compliance is a measure of the lung volume. I think of it in my mind as a measure of the stretch that the lungs have. Let's talk about assessing the ventilation. And for doing assessing ventilation, we use an apparatus known as spirometer. You saw that in our lecture slides. It was this plastic thing where you breathe in. You do get fancier ones that are more of a computer connected, so we can get data out of there. And let's look at different kinds of respiratory volumes to start with. Let's start with the tidal volume. Tidal volume is the amount of air that is normally moved in and out as we breathe. So just during the regular breathing, how much air gets moved. The next one that I want to add here is gonna be our IRV. That refers to the inspiratory reserve volume. So inspiratory reserve volume is the measure of the maximum amount of air that can be inspired, so breath in with a force beyond the normal tidal volume. The next one that we're ready to have a look of is gonna be our ERV, expiratory reserve volume. That's in part the amount of the air that can be forcefully expelled, breathed out beyond the tidal volume. And finally, we're left with something called residual volume. Residual volume is the amount of air that always remains within the respiratory system that we never can quite get completely out of. So there's always going to be some within the respiratory tree or within the alveoli that are not functional, or so on and so on. Well, now that we have had a look of the respiratory volumes, we can have a look of respiratory capacities. Well, inspiratory capacity. Inspiratory capacity is calculated. I'm gonna just quickly change my pen color. Calculated by adding together. I still didn't get the stick. Now we have better luck, I feel. So inspiratory capacity is when we add the tidal volume and inspiratory reserve volume together. That gives us the inspiratory capacity. Functional residual capacity then. Let's have a look of that. Functional residual capacity is calculated by adding together the residual volume and expiratory reserve volume. If we want to calculate one's vital capacity, we take the tidal volume, our inspiratory reserve volume, and our expiratory reserve volume, and add all of those three together. Finally, if we want to calculate the total lung capacity, that of course means adding all of the volumes that we had a look of together. So that will be our tidal volume, our inspiratory reserve volume, our expiratory reserve volume, and our residual volume. So there you can see quite nicely all of these explained in this diagram. And I'll just highlight them so that it's easier for us to have a look of those. If you are a visual learner and you benefit from colors, that might be something that you might find useful. Again, you do whatever works for you. These notes are for your own use, so Whatever you find that serves your learning, that's what you should be doing. So next thing that I want to talk about, I mentioned or touched upon this topic a little bit, but I didn't go into too much of a detail. We can have something called dead space. Dead space is the amount of the air that either remains in the passageways or is occupied by non-functional alveoli. Both of those together gives us the total dead space. We can have anatomical and alveolar dead space depending on which one we're looking at. In terms of the gas exchange, we had a look of that earlier on when we discussed the phases of respiration. Let's go here. You remember this diagram here? Well, we can highlight external and internal respiration. And remember that the driving force for the gas exchange on these was the partial pressure differences between the gases on two sides. And let's start with the external respiration, and we're going to have a look of what sort of values can we see there. And we're going to start by looking at the oxygen. So the partial pressure of the oxygen within the blood that's returning from the systemic circuit to the alveoli is 40 millimeters of mercury, whereas in air we have 100 millimeters of mercury for the partial pressure of the oxygen. Well, of course, 100 is greater than 40. So for that reason, the flow of oxygen, movement of oxygen is going to be from the alveoli to the capillary blood within the external respiration. Let's have a look at what happens to the carbon dioxide then. Well, carbon dioxide concentration in the blood that's returning from the systemic circuit through capillary blood is 45 millimeters of mercury. The partial pressure of the, I didn't mean to do that. Partial pressure of the, that looks better, of the carbon dioxide in the air is 40. And we remember, of course, that 45 is greater than 40. Carbon dioxide moves from the capillaries of the pulmonary system to the alveoli. Now let's have a look at the external. When we covered the external respiration, we're ready to move on to look at the internal respiration. So we have this blood that we saw. Ooh, I want to be using a highlighter. Let's get that chosen. Oh, I didn't still need to change that. That looks better. So we want to start by looking at the oxygen. So we remember that now oxygen concentration in the blood that's coming to the systemic circulation is gonna be 100 millimeters of mercury, because that was what the concentration within the normal air was. But oxygen concentration within the tissues is gonna be 40 millimeters of mercury. So for that reason, oxygen is going to be moving from the capillaries of the systemic circulation to the tissues or interstitial fluid. Let's look at what happens to the carbon dioxide. Carbon dioxide concentration in the blood coming to the systemic circulation is 40 millimeters of mercury, 45 in the tissues, in the interstitial fluid. Well, of course, 45 is greater than 40, so the movement is from the tissues, from the interstitial fluid to the blood. So remember the partial pressure concept. We move from areas of high concentration to areas of low concentration until the concentrations are equal. Let's have a look at how these different gases are transported in the blood then. And we're going to start with the oxygen. So majority of oxygen is transported in the blood as bound to the hemoglobin. So remember the heme groups within each red blood cell, 4 of them, capable of carrying 4 oxygen atoms at one time. A small amount, about I would say 2%, is transported bound to the plasma. Carbon dioxide instead is transported within the blood about 3/4 as a bicarbonate, about 15% bound to hemoglobin, and about 10% in plasma. We can have a condition where we have hyperventilation taking place. What is it when we have hyperventilation? That's when someone's breathing too fast, too deep. They might be very upset, and we talk about them being hyperventilating. This is dangerous because you can get rid of too much carbon dioxide, and as a result, that would be a problem for our body. That covers our chapter on the respiratory system, and what we're next going to look at is going to be the urinary system. And you remember when we talked about the urinary system, I mentioned to you that our main focus will be on this structure called nephron within the kidneys. But we are going to talk about all other parts of the urinary system as well. So we will do a comprehensive review, but our focus will be on the nephron. A urinary system has many functions. I think that I shared with you that I got to about 100 functions at one point and I gave up. But the most important functions that we are going to look at is the blood pressure regulation and fluid water concentration and volume regulation. If we describe a kidney, it is kind of this bean-shaped structure, if you wish, located within the posterior part of your body. So it is kind of further back than what most people typically end up thinking when I discuss with them. So your kidneys are fairly close to the back of your back. So just something to bear in mind. Kidneys have certain parts that we want to know there. So let's have a look of those. So medially, we see that the kidneys are concaved in a shape. And we have there the renal hilum. That's where the ureter enters, or actually leaves from the kidney. But also various blood vessels are coming in and leaving. And we have nerves coming in and leaving. And we even have lymphatic vessels coming in and leaving. Or really leaving. So you'll notice a lot of stuff going to the kidney. And that was on the convex medial side. The lateral side, or that was the concave medial side. The lateral side is convex, and that's kind of a larger, smoother, rounder curvature. One thing that's striking, noteworthy, is that the kidney is smooth, very smooth and shiny from the surface. That's because it is enclosed within the fibrous renal capsule. If we discuss the location of the kidney in relation to the peritoneum, it is going to be retroperitoneal, so behind the peritoneum. Another thing to note that I think is noteworthy is that the right kidney is located higher than the left kidney. And this is because we end up finding that especially on the left side, a large proportion of the space is taken by the liver that's located on top of it. So that causes the left kidney to be located a little lower. If we look inside anatomy of a kidney, let's do that. I'm going to sketch a quick kidney here for us. So let's do our ureter. Let's do our medial and lateral side. I'm gonna do also a little bit of branches here. And what else could I do? I could do the renal pyramids. We're gonna color these together, so that's a good way of going through them. So, as with most structures, we've seen this, for example, with the brain. We have the outermost part, the most superficial part, which was known as cortex. So similarly to that, kidneys have a renal cortex, the outermost layer of the internal anatomy. And then we have the deeper part, which is known as the medulla. And within the medulla, we can see structures that are going to be actually rather important for us to note. The renal medullary pyramids, or renal pyramids, sometimes referred just as themselves. And these were the ones that I drew here earlier on when I was sketching. They're kind of a triangular shape, larger end facing outside, and darker in tissue color than the rest of the renal tissue. And then we have these collecting parts, are minor and major calyx, which lead into the renal pelvis. And from the renal pelvis, we have the ureter coming out. And that's one of the structures that we'll have a look in just a second. So this is our ureter of the kidney. So there's the flow of the material through the kidney listed as well. And we're going to talk now about the structure known as the nephron. A nephron is an important structure. It is both the structural and functional unit of the kidneys, of the urinary system. And there's a bunch of parts of the nephron that I want you to be able to be familiar with, to identify from a diagram. And to remember, and I'm saying this because I have had a debate about this back in the day with a student who said that, well, diagrams always show nephron running from one way, from the left-hand side to the right-hand side. Nephrons can be any way around. I just draw them one way to make it easier for you to follow, but there's no reason why nephron couldn't start from the right and go to the left. So to flow through that. But what we see here is a diagram of a nephron, and I'm going to zoom out a little bit so we can see it all in one view. And let's identify structures within there. So first of all, we have our afferent arteriole coming in, and of course our efferent arteriole leaving the nephron. We also see our glomerulus, which is a capillary network here. And then we can see, I'm going to change the color of the pen. We can see our glomerular capsule, or some prefer to call it Bowman's capsule, surrounding the glomerulus. And from the Bowman's capsule, we have our proximal convoluted tubule. And then we have our nephron loop, sometimes known as loop of Henle. And then we have our distal convoluted tubule. And finally, we have our collecting duct here. And collecting duct receives the secretions from multiple nephrons together. One thing to notice that I want to add to this diagram is notice that the smallest capillary vessel runs all the way around the nephron, so making a close contact with these various parts, enabling materials to move in and out as needed at various stages of the process as we look at the nephron's functions. So on that note, we are able to take one step further and identify movements of the fluids. And let's go through those. And we're going to start with the process of filtration. In filtration, we get material from glomerulus, so this capillary network, moving to the glomerular capsule or Bowman's capsule. So blood gets filtered and stuff gets taken out from there and dumped into the nephron. Then once we get to the end of the proximal convoluted tubule, and beginning of the nephron loop or loop of Henle, if you prefer to use that term, some of the material actually gets moved, and I'm trying to find just a pencil or highlighter, gets moved from the nephron to the capillary to the that goes next to the nephron. And next one that we'll have a look is gonna be, that was known as reabsorption. Next one that we're gonna have a look of is gonna be secretion. In secretion, we have material moving back from the blood, from the capillary, to the nephron, in particular to the nephron loop, beginning of the distal convoluted tubule. And final stage of the movements is gonna be excretion, which is all the material put out from the nephron to the collecting duct. So really, if you wanted to, if you're into math, you could make a statement that our excretion is equal to what gets filtered minus what gets reabsorbed plus what gets secreted. So you could use that as a formula if you're kind of wanting to clarify to yourself the movement of each of these materials in a nephron. I don't know if you find it useful. Some students of mine in the past found that helped them to remember what was going on. Well, let's zoom in a little bit and discuss a little bit more about the nephron, keeping in mind the important things that we want to notice from there. So I want to talk about a measure known as GFR. That's the glomerular filtration rate. That is basically a measure of how well the kidneys are doing. Let's go a little closer. So it measures how much blood passes through a glomeruli in a single minute. And here comes the hormone that I think that you know from the past. This is a hormone that we have had a look back in the day, and the name of the hormone is ADH. And you might remember that ADH stood for antidiuretic hormone. So antidiuretic hormone makes us produce less urine. And how this happens is that the wall of the distal convoluted tubule becomes more permeable in presence of the ADH, and as a result, more water enters back to the cardiovascular system. So we end up making less pee. Next structure that we should have a look of, and let's draw again a really quick, nice diagram. We have already talked about our kidneys, with the right kidney being higher, with the left kidney being higher and right kidney being lower. Then we had from there, from kidneys, the ureters coming out. And ureters led to the urinary bladder, to the base of there. And from the urinary bladder, we have our urethra. So let's discuss these. I lost all of my drawing tools. Let's get them back. So we just discussed the kidneys and we discussed the nephron, which is the structural and functional unit of the kidney. And next we will have a look of the ureters. So ureters are these tubes that run from the kidneys to the urinary bladder. They are about 25 centimeters in length, actually loop around the urinary bladder and enter from the base of it into there. They are located behind the peritoneum, so being retroperitoneal. And one important thing to notice about them is that they're made of smooth muscle. This means that the urine will keep moving from the kidneys to the urinary bladder, even against the gravity. So if you were standing on your head or you were in space, urine would still be moving from the kidneys via ureters to the urinary bladder. Next structure I want to talk about is, not surprisingly, the urinary bladder. Urinary bladder, if you really want to simplify things to the very core, it's just nothing else but a temporary storage pouch for the urine. So it is made a sac that's able to extend and shrink as needed. And it as well is retroperitoneal, located at the pelvic floor. One thing that we do notice at the urinary bladder, if we take a view of it, let's cut it in half like this and have a look what we will see. We are looking from the top down. Here's our urinary bladder. And there's going to be 3 openings at the bottom. And I'm going to color the urinary bladder with the color that we were using earlier on, just to be consistent, so no one feels that it gets complicated because the colors keep changing. So this is all our urinary bladder. At the base of the urinary bladder, we see 3 openings, and we'll discuss about those. So 2 of those we are already familiar with, and these are of course the 2 ureters which opened at the base of the urinary bladder. And then the final structure, which we will be looking at, which is of course going to be the urethra. And urethra is the tube that carries the pee from the urinary bladder to the outside world, draining the bladder. Again, it's a muscular tube with many sphincters. So there are some involuntary, which are mainly the inferior ones, interior ones, and external ones are more of voluntary ones. We noticed that the length of the urethra differs between males and females, much longer on males. This means that the females are more likely to get UTI because the distance for the bacteria to travel to the urinary bladder through the urethra is much shorter. Well, but I didn't finish ever discussing this section that we drew where we saw the 2 ureters and 1 urethra. If you look at this section, base of the urinary bladder that we've drawn, one thing that you'll notice there is that these 3 openings form almost like this triangular shape to the base of the urinary bladder. This is known as trigone. So trigone is this triangular space, and another useful anatomic landmark which you might use sometimes in clinical practice. Finally, a term that I really do want to highlight in terms of using proper terminology, when we talk about micturition, micturition is the term for urination. Proper medical, physiological, and anatomical term to use. Let's have a look at the composition of the urine. We should find that majority of the urine, about 95%, is made of water. We do find various different solutes such as urea, uric acid, and creatine, and various other elements. But one thing we should never find in urine is blood or red blood cells. That would be a problem. That would be something that would be cause of concern. We do not want to find too high concentration of any of these components that we just had a look of either. That would be a cause of concern if we're far off from what we normally expect to see. White blood cells as well a problem. Blood proteins, bile pigments, all of those things we don't want to find in the urine. And that completes our review of the urinary system. And we are left with one more chapter to look at. And this chapter that we're going to discuss next is going to be all about the fluid, electrolyte, and pH balance. So kind of continuation of considerations that we started in terms of the physiology of the urinary system, but taking it a little bit further. So the main importance for that, which I discussed with you, was that when we properly understand the basics, what's normal, fluid, electrolyte, and pH values, we can also understand lab tests in terms of what is abnormal. So we need to learn the typical first before we can start to learn abnormal things. Let's have a look at the amount of water in human body. And what we end up noticing is that majority of all living things are made of water. And same is true for the humans. If we look at adults, in males, there's a little bit higher concentration of water than in females. That's mainly because females have a little bit higher body fat content and less skeletal muscle mass than males on average. We also notice that infants have higher water content because of their low body fat and low bone mass, whereas elderly people have a less water content in their body. Let's look at the locations of water. Where do we find water in the body? And again, to make things a little bit simpler to visualize, I'm drawing a couple of pictures, or a picture here with a couple of structures. So what we see here is a bunch of cells with their nuclei showing up nicely. And we will start by talking about intracellular fluid. And what intracellular fluid means is that this fluid is located inside the cells. And this is about 2/3 of all the fluid in the body that's located inside the cells. And the other concept that I, of course, do want to discuss very briefly is then the extracellular fluid. So the fluid that's located elsewhere, but not inside the cell. That's about 1/3 of all the fluid. So this can be interstitial fluid or blood plasma or lymph, for example. But regardless, this is fluid that would not be located inside the cells. Let's have a look at some of the characteristics of the water. And this should be a revision from what we have seen in BIO181 or BIO156. So I'm going to go through that rather quickly. We notice that water makes excellent transport media. And in fact, this is why most of the blood is water. It's a great way of transporting gases, nutrients, waste products, hormones, and so on. But it doesn't just have to be animals that have blood. Also, plants utilize the water to transport the nutrients, for example. Then two concepts: cohesion, which is the attraction of water molecules to other water molecules, and adhesion, which is the attraction of water molecules to other polar surfaces. And then we have the surface tension of the water. So that's due to the cohesion of the surface. So bugs can walk on the water because of this, for example. Water also works as a great temperature reservoir. So it evens out the changes of the hot days and cold nights at the coastal areas. So that's why the temperature changes are lesser at the coastal areas, and coastal areas are in general more preferred to live on. Water has different phases that it can take: solid, liquid, and gas shape. There is a fourth one that we're not really looking at, but some elements can take a form of a plasma as well. Finally, the last point that I want to highlight, that's again another really important thing to notice, is that water works as a great solvent. So many things are able to dissolve into the water, many solutes. And there's a bunch of materials that do not dissolve, such as glucose, lipids, ureas, and creatines. Those are not as big of an interest to us as the materials that dissolve, because as these materials dissolve, what we notice is that there's a change in the charges of these materials. So if you look at all these chemical symbols that I've included here, we end up either with positive or negative charge on all of these. And this would be really important in terms of how they are going to behave as we move further. And super important theme to notice, if you learn nothing else about this chapter, do remember that wherever the water goes, electrolytes will follow, and wherever electrolytes go, water will follow. So basically, what I'm trying to say here is that water and solutes are interdependent. So they depend on each other. Okay, let's have a look at the amount of water intake and amount of water output. One thing that we notice right off from the bat is that these should be equal. We should be taking about the same amount of water in as we are putting out to remain in balance. The main driving force for water intake is the thirst. So you get about 2/3 of all the water in your body simply by drinking. In addition, small amounts through moist food, and as a byproduct of metabolism, water often results as that as well. Well, how do we get rid of the water? The main route of exit for water is through urination. Again, about 2/3 of all the water lost. In addition to evaporation, sweat, and breathing are the ways how water leaves the body. Small amount through feces as well. I have talked about the concept of homeostasis in the past, so that shouldn't be a surprising concept for you to run into. Very basic. So homeostasis was all about the maintenance of constant internal environment within the body. The reason why it was important for us to learn this was that homeostatic control mechanism loop, which we can see here, can be used to explain various different processes. And in this case, we are using it to explain a concept of osmoreceptor ADH mechanism. And rather than learning something complex, I have simplified it to you simply by using this homeostatic control mechanism loop. So we're going to review this rather quickly, but we will review it nonetheless. Let's think of a situation where we have too much water in the body. We want to get rid of some of the water. What could we do? Our osmoreceptors at the hypothalamus serve as our sensors. They pass the message to the brain, where we have the set point, which is basically the normal, what the amount of normal water content in the blood should be. If that is too much, like we are here noticing through the osmoreceptors and compared to the normal values, well, now our pituitary gland will start secreting less ADH. And when we have less ADH, we have more water leaving the body. So we end up excreting more water, producing more secretion from the nephron. So we end up peeing much more water. That's how we get rid of the water. Let's look at an opposite of that, where we have now too little water. So you could almost say that the water is too salty if you wish. That's our starting situation. Again, our sensor is going to be the osmoreceptors at the hypothalamus. They pass the message to the brain, where we have the normal set point where we compare this value. So we compare whether the sensation from the osmoreceptors is in alignment with what would be normal. If that's not, we start to make more ADH, antidiuretic hormone, which results in more water being taken back. So more water is now being taken back to the blood, and as a result, less urine is being made. So you end up urinating less and start to save all the water in the body. So that's the two important concepts of the osmoreceptor ADH mechanisms explained in a very simpler manner. And we are ready to start to look at a concept of tonicity. Again, a concept of tonicity should be something that's familiar to you from the past, but just for the sake of being safe, I am going to review that with you. And let's start by looking at a situation where we have hypotonic conditions. In hypotonic situation, we have the inside of the cell containing more solutes, more salts, more electrolytes, whatever you wish to put in there, than the outside of the cell. Well, as a result of this, now body always try to balance of these proportions. And as a result, in this case, water starts to flow inside the cell. This would lead into the water, causing the cell to swell, and it might even eventually end up bursting. So you asked me how to remember this. I think I told you my tip, my trick to remember this is that whenever I hear a hypotonic cell, I think of an animal called hippo. And this is not going to be the greatest drawing. Sorry, it looks more like a pig than a hippo, but that's the best I could do. So hippos are these big, swollen animals. They sound a little bit like a hypo. So I think that the hypotonic cells are big, swollen cells. Well, let's have a look at the next one. The next one that we're going to have a look of is isotonic cells. In isotonic cells, the concentration of salts or electrolytes or solutes, whatever you wish to look at, is the same both inside and outside the cell. So as a result, some amount of water will move into the cell. but an equal amount of water will also leave the cell. So in total, there's zero net gain or net loss. So it remains the same, the cell's size. So how do I remember isotonic cells? I think of perfect. I don't have to change, I'm perfect. So that's my way of remembering the isotonic cells. And that leaves us with one more type of tonicity to have a look of. And this one will be, of course, our hypertonic cells. So let's have a look of what's happening in hypertonic cells. So in hypertonic cells, the inside of the cell is fairly dilute. Outside of the cell instead is more saltier or has more electrolytes or whatever you wish. Well, you remember that human body always tried to balance off things. So how are we going to do that? Well, we're going to do that by transporting water out from the cell, and that causes the cell to shrink, and it might even eventually dry up. Well, how do I remember this? Think of a person who's hyper. What do hyper people do? They do end up running a lot. They're super active. And what happens if you run a lot? You become very skinny. So hypertonic cells are my skinny cells. So if that helps you to remember that at least works for me. That takes us to discuss a little bit about the importance of the recovery drinks. So replacing the electrolytes in the drinks, it is important to have electrolytes. And in addition, some of those added materials on those drinks also enhance with the water uptake. Finally, final thing to talk about a little bit is gonna be our pH scale. So let's discuss the pH scale a little bit. So really we remember that pH scale ran from 0 to 14. In the middle of it, we had pH 7. pH 7 was neutral. And what pH scale really is, what it tells us about the amount of hydrogen ions in a substance. So if we have high pH, that would be basic or alkaline. And if we have low pH, that would be acidic. So low concentration of hydrogen ions. When we look at the human body, one thing that we'll end up noticing is that the pH range within the human body is maintained extremely consistent from somewhere in the blood from 7.35 to 7.45. You can still live up to as low as 6.8 and as high as 8.0 pH. But usually this variation is simple of 0.1 pH. That is very, very narrow range, and that's quite an accomplishment. If my students ever, we do experiments where we're trying to mix a liquid of a pH, of perfect pH, by adding acids and bases, and it is tough, I tell you. Well, how human body is so successful in this? That's thanks to 3 different mechanisms that we have. First of all, we can use something known as buffers. And in my classes, in my Bio 156, my students had test out different materials. We end up finding that certain chemicals bind really well to acids and bases, so they neutralize the concentration of a substance really, really well. So we can use chemicals as a quick way of neutralizing, eliminating the changes in the pH values. The other way to deal with the changes in the pH values is, of course, through respiration. This takes about a few minutes to happen, and we simply breathe out whatever we don't want to have in the body. And final, the slowest mechanism, but also the most potent mechanism, is by kidneys by producing urine. So that's our renal mechanism. So I would say that that's the most efficient, but that can take also longest time to act, anywhere from hours to even days. So those are the 3 ways how our body deals with the pH changes. A clinical relevance of this, of course, goes to the concepts of having alkalosis or acidosis. Both of these conditions are examples of when we have either too high or too low body pH. And you can look at the video that I prepared for you for the lecture video, or one of the review videos from last week's chapter, where I discuss some of the signs and symptoms of both of these clinical situations. I want to wrap up the chapter on the fluid balance, pH and electrolyte balance, by talking about fluid therapy. Fluid therapy is, of course, administering IV drip. So basically what I described it as was expensive salt water. This was because there was just right amount of electrolytes dissolved into this fluid, so that our body pH remains constant, so that we have right amount of electrolytes for body to function and do all of its functions. This water, of course, also has to be sterile. So it is some concept that's important. We will be seeing that a lot if you go to clinical practice. One of the very first things that we end up doing with the patients a lot of the time is, let's put a drip of IV fluids flowing in to ensure that they're going to be fine. So that, on that note, completes our review of the chapter material for this exam 3, and let's save it on our notes. And I'm going to stop sharing this and jump back to our initial presentation. Provided that I can find the sharing tools. Here we are, back on the game again. So now that we have gone through the study guide for the exam 3, I want to remind you that I also have lists of important structures and concepts for the practical 3, covering those chapters that we covered. I strongly recommend that you consider whether doing the practice lab practical would be useful for you. I would consider doing it a few times through. And remember, you do have handouts for the lecture material. It's not the exact same slides as I use, but your publisher's textbook slides of the material of the chapter. And to kind of remind you, I am happy to reopen extend assignments. Just message me on Canvas. I do have a couple of those requests, and I will get those processed as soon as this session is over. And remember, we do have tutoring available. You do not need to have an appointment scheduled. You do it through the Cranium Cafe, which is the tool that the college has decided to use during this pandemic time when we're still largely working virtually. If you have any questions, one of these review sessions is a good time to come and address those. If you have any questions about the exam material, about basic concepts, or any practical issues, I am here to help you. I also am happy to tutor you. I do a little bit of that just because I think it's the right thing to do. So contact me, no worries. I have a lot of office hours available this week. I have these review sessions, and you can always reach me through the Canvas messages as well. And on that note, that completes everything I had planned for this session. So we have covered the exam pre-study guide. That was what I wanted to spend most of our time. Remember to do for the lab practical, also the practice practicals, they might be useful. Remember, it's an open book test. It is usually time limited. So depending on your recommendation plan, you might have adjustments from that. And it is due at the end of this week. Any assignments missing, I will go through those messages that I have received, and you can send me a new one if you haven't heard back from me. I appreciate your hard work on this course. We are almost there with wrapping up the semester, so let's finish off strong and let's make it a very, very good week 14. I'll see you at next week's session. Thank you. Bye.